Welcome back to yet another episode of Sex Talks Podcast with me, your host, Selma Ndasilohenda Iyambo. As always, I'm super excited to be here with you, and I'm beyond grateful that you chose Sex Talks Podcast once again. If you're a first-time listener, welcome to the Sex Talks Podcast family. Here, we are all about creating an informed and educated society of young people who can openly have conversations on sexual health matters while sharing their personal stories and hearing from experts in the field. We are recording yet another episode live from the Be Free Youth Campus thanks to our collaboration with the Be Free Studios under the One Economy Foundation. You can find this youth-friendly space at the Windhoek Multipurpose Youth Center or online at Be Free Namibia. Joining us in studio today is Dr. David Emvula, a specialist in obstetrician and gynaecologist with over a decade of experience in women's health. Dr. Emvula completed his medical degree at the University of Pretoria and his specialist training in obstetrics and gynecology, earning his fellowship and master's in 2020. He also holds advanced certifications in laparoscopic surgery and reproductive medicine, including a master's in sexual and reproductive health medicine from the University of South Wales. Dr. Emvula has a strong passion for minimally invasive surgery and reproductive medicine, with a special interest in infertility care. He's a part-time fellow in reproductive medicine at the Tygerberg Hospital and Life Vicente Pallotti Hospital, and is a member of several professional organizations, including the SASOG, SASREC, and ESREC. Sure. Yes. I need a breath after taking that whole introduction and reading a lot of this acronym. But Dr. Emvula, welcome back to the Be Free Youth Campus once again. How are you doing today?
Good day, Selma. Thank you for having me.
How does it feel to be back? And this time you're not seeing clients, you're actually here to have a conversation about something that you do on a daily basis.
Yeah, the last time we were here, it was when we had the outreach campaign. That was quite an eye-opener and yet overwhelming experience.
Yes.
But we had a very good day and a successful outreach. And I'm happy to be back.
And we cannot wait to have you back because we still have more people asking about when will you guys have another outreach. Now, Doctor, we are grateful that you took time to be able to share your expertise in gynecology. And today we're having a conversation that is quite crucial seeing the society that we live in. And for many young people, when they speak of contraception, and when you go to a parent or somebody older and you tell them, I'm going to the clinic to get pills, I'm going to go to the clinic to get an implant. The first thing is you want to be infertile because that's the conversation and the notion around it. But what's infertility and how is it typically diagnosed?
All right, good. I think it's quite a very important topic to raise awareness around this topic. When you speak about an infertility, by definition, it's defined by the World Health Organization, depending on the age of the patient. And I say the age because we look at the two different aspects: before 35 years old and after 35 years old. So for a woman who is less than 35 years old, and we are saying a woman because we use the woman as a reference in terms of definition of infertility, that women that are less than 35 years old, they can be diagnosed with infertility if they fail to conceive or fall pregnant regardless of the outcome of the pregnancy for a period of at least 12 months or a year of regular unprotected sex. Then already, if that's the case, it is highly advised that then the patient, then they must seek medical care to be assessed if they indeed have an infertility. And then for those ones who are older than 35 years old, we ask them to at least to be sexually active on a regular, frequent basis for a period of 6 months before they can seek care. Perhaps the question that always comes out, what is a regular unprotected sex? Is it every day? The answer is not every day, but we advise at least 3 times of unprotected regular sexual intercourse per week. If there is no baby within those specific time frame that I highlighted, then it is highly advised that the couple must then seek medical care to be assessed if they indeed have an infertility. Mindful that even beside being able to conceive within that time frame, they can be assessed and they may find that there's really nothing wrong, but in most cases that with more time of exposure to regular unprotected sex from a year to 2 years, you find that more than 90% of people that try that for at least the longer you try it from 12 months to another 2 years, they will fall pregnant.
Doctor, I listened to you give us this definition. I'm wondering, what are some of the causes of infertility? Now, given that you gave us 2 age categories.
Yes. So the causes can be multifactorial, but we usually, from the clinical point of view, we divide them into 2 groups, into what we call male factor infertility or female factor infertility. In other words, when the couple comes to us, when there's an infertility problem, we advise that people, the 2 people that are involved in the relationship must come seek health together, because infertility by definition is not yes, we may find a problem with one of the couple, but it's a couple problem. So we try to assess the 2 people together so that we try to find out the factors. When we speak about the female factor infertility, the most common ones that we see is it can be tubal factor, in a sense that if you have the tubes that are blocked, there is no way the tubes or the fallopian tubes it's a place that is found on the womb, and this is a place where the fertilization takes place. In other words, the egg and the sperm meets to conceive a fetus. And if those small pipe, which is quite very tiny, it can be blocked, mainly caused by infections, specifically sexually transmitted infections like chlamydia, then there is no way, it's like a roadblock. The sperm will never be able to pass that roadblock to fertilize an egg. That is one of the most leading causes of infertility, especially in the African context. And then you have other conditions that can be uterine factors, which meaning that the womb, typically the womb itself, the main role of the womb is to carry the pregnancy, not necessarily to conceive, except the fallopian tube. But sometimes you find that within the uterus, there may be abnormalities, especially abnormal growth such as fibroids, which can also then impede or cause obstruction of these tubes. And then in that way, they may contribute to infertility, depending on where they are located. Other factors can be conditions such as endometriosis. Is one of the common conditions that some women, certain percentage, about 10% of women that have, is associated with infertility. And in terms of endometriosis, it causes infertility in many ways, such as reducing your egg quality, such as also causing tubes to be blocked as a disease. And then you may also have many other factors where some women have their eggs finished at a younger age.
What does that mean, doctor?
We call it ovaries failing, but the terminology is usually called premature ovarian insufficiency. But in simple terms, it just means that your ovary has failed at a younger age, or otherwise you reach menopause at a younger age than expected. So that can be as a result of just autoimmune, meaning that it just happens. We can't really find the cause. And then the other ones can be viruses. If you have mumps as a child, or if you had a cancer treatment as a child, it can affect those, and then it can. And then those are some of the common female factors. When you speak about male factors can also be the other. Just quickly, maybe recap on the female. It can be congenital, meaning that the way as a woman you may have abnormalities related to genetic makeup. So there are women that have instead of having normal 46 chromosomes, you only have 45, such as Turner syndrome and many other ones. The same also goes for the males, in the sense that you can get the opposite that happens in the females can also happen in males, except for the tubes that we spoke about. But the males, the lifestyle also really plays a role in terms of males. And lifestyle habits such as smoking, drinking alcohol, even if we wear a lot of underpants that are pushing up the testes, because naturally the testes are hanging away from the body for a purpose. It has to do with sperm production. So all these lifestyle factors can contribute to having for example, low sperm count. And if there is no sperm, then it means that there's you can't fall pregnant, even if there's semen that is ejaculated. So the production issue can be related to lifestyle. And then you can have some males can have blocks through the tube where the sperm must travel, or we call it obstructive, that can prevent the sperm from traveling and reaching the egg. And then you can also have now the testis itself, where you can have a testis that is failing itself, like similar to the females. It can also be cancer-related treatment. It can be viruses, or sometimes we can't explain it. We call it idiopathic. Then you also have a group where you have genetic causes, where you also have males that have a genetic makeup, that abnormality, and also other systemic conditions that can occur in both males and females, such as other medical conditions that are related to endocrine, such as thyroid problems, other in both males and females, or any other disease that have an impact on that. So at the end of the day, when a couple comes to us, we see them as such, and then we try to take history on both of them. And then we try now to do what we call targeted investigations, depending on what we pick up from the history that the couple presents with in terms of to make the diagnosis. So it will be one cannot really just make a diagnosis without really taking good history examination and also some other investigations.
Thank you for breaking down as to what are some of the causes of infertility, doctor. Now, looking at it from the perspective of women and men, saying that both are able to take contraceptives, can contraception or contraceptives be a cause of infertility? And if yes, how so?
So the answer is no. Contraception does not cause infertility. Mm-hmm. However, what we need to understand is that, yes, in a sense that the aim of contraception is to prevent pregnancy. It's not forever. Mm-hmm. Contraception are meant to prevent pregnancy temporarily, and the moment you stop them, you should be able to return to your normal fertility as before you have used the contraception. So it is a myth that is common. But however, what we have found is that the link between contraception and infertility is related to lifestyle and behavior, in a sense that when a woman, we are saying a woman because the contraceptive options that we have available are mainly for women. When a woman opts for contraceptive options, there is evidence to show that their behavioral in terms of sexual life changes. Instead of using barrier methods, specifically condoms, to prevent sexually transmitted infections, they know that they are covered for the pregnancy. And what we are seeing is that there tend to be a high incidence of unprotected sexual intercourse, which predisposes these women to being at risk of contracting sexually transmitted infections, more especially for the chlamydia that I highlighted earlier. And then later years, when now these women like I said, on a temporary basis, now they stop using this contraception, they are now ready to start a family, and they find themselves now with not being able to conceive. And then that is where, but most of what we see with this group of patients is that at some time in their lifetime when they were on contraceptive, they were probably engaging in unprotected, and they end up with sexually transmitted infections, which ultimately leads to tubal factor infertility. So that is the link that is very well described.
Now, doctor, give me an example in a situation whereby, let's say now I got an implant or I had an IUD at some point in my youth, right? And after a few years, I realized I actually want to start a family. Is the time frame still the same compared to someone that was not on a contraception? And how long should I wait until I go to seek medical attention to say that maybe I'm infertile?
Yes, most definitely yes. So this, maybe to put it simple, is that depending on the type of the contraception method that you use, mm-hmm. it may have an impact on what we call a return to fertility time after using a contraception. But specifically the one that you highlighted, the loop, if we remove the loop today, the next cycle you can conceive. Because, for example, a loop does not prevent you from ovulating. The loop rather have ways of preventing the pregnancy in different ways. It has nothing, so meaning that all the time, even when you are on the loop, you are still continuously ovulating. So you are likely to ovulate the following month, and you are likely to fall pregnant immediately. The same goes for the implants. However, the medication that has been found to have a little bit of a delay in terms of return to fertility is drugs such as Depot and these injections. And we say injectables because once we give you injections, is that your body must absorb them at a constant, slow rate until they are cleared from your body. And that is why sometimes even after getting an injection, today it may take up to 6 months to up to a year. It's acceptable for the body to clear off that medication. And to put it in context is just to understand what it means. If you look at someone who is diagnosed with a mental health condition like schizophrenia, these patients, they are usually given an injection, and that is what able to keep them without taking medication for months. It's the same way in a way that, because after every injection it stays in your system, it has to be continuously removed. But the other drugs, once they are out, they're out, because the medication, for example, for the implant is not in your system. It is on the implant itself, and if it's removed, it's out of your system. The same concept. And the other ones, such as pills, if you stop them, you fall pregnant.
Okay, now let's look at the situation of the injectables. What's the average time for one to actually wait until the system is cleared for you to fall pregnant?
So like we said, especially for Depo-Provera, usually it's acceptable. So if someone, we get worried if you go beyond a year without your periods returning, in other words, returning to fertility, then we should now start maybe consider to do more investigations. Why are they not coming back?
All right. Now let's speak about the myths that we looked at contraception being one of the ones that is overlooked as a cause of infertility. What are some of the other common myths that you've heard around infertility?
So obviously there are many myths. The most common one is the infertility cause, but there's also others such as the risk of a patient getting a baby with abnormalities, or as an explanation of why, if you have used contraception before. But perhaps to make it very simple is that we need to understand that contraceptive drugs or any medication that we're using, they are as equally safe as any medication that we use. For example, Panadol, we drink most, is one of the most used drug. It's as safe as that, because prior to any drug getting into the market, behind that drug, there's years of clinical trials before it is, and this can be, to put it in context, it can be, if you remember very well with COVID, it was also highlighted that, for example, COVID vaccine, there were steps that were jumped because of the emergency and criticality of the situation. But most of these drugs, they are relatively safe. They are relatively effective at doing what is expected of them to do, which is to prevent pregnancy. And they have not been found to have any other serious side effects. The other one is also patients who come to us, for example, saying that I'm not feeling well because I'm not bleeding. And they can say, if they are using a contraception, it is physiologically, it is not necessary that a woman must see blood every month. It doesn't have any benefit. The reason a woman you only bleed for one reason. It's your body telling you that the last month we did not fall pregnant. We are starting a new cycle to see if you can I'm giving you another chance for you to try and conceive. Because at the end of the day, the reason why women menstruate is not for fun. It is to reproduce. That's all. Menstruation cycles is there for it is there for reproduction, as it is. And if you don't see your periods, it's not a sin. It's actually because you are using contraception to prevent you from falling pregnant. And that is why children don't see periods, they don't fall pregnant. If you reach menopause, you don't see your period, you don't fall pregnant. So the only reason we menstruate is for one reason, to reproduce. Well, so it doesn't have beneficials. It doesn't have health benefits. Okay.
Well, doctor, I'm smiling because I'm one of those people whereby if I don't get my period for that month, I question a lot and I'm like, is
So if you don't get your
wrong?
periods, the first thing that you must do, you must do a pregnancy test. Yes, that's what we are told as well as we are training that a woman is pregnant until proven otherwise.
Yes. Now, in the context of situations like cultural beliefs that when you bleed every month, you're able to get rid of the dirty blood, and it's something that somehow is instilled in us to an extent that even when you are choosing a contraceptive method, you ought to think, when I get to see my cycle. And I was having a conversation with one of the nurses from now our B3 youth campus when I was choosing a contraceptive method, and I was like, will I be able to bleed every month? He's like, but if you get it depending on what you want to get, you might not be able to bleed. And that's, I was like, implant? Leave it out, because I personally love to see my blood. And these are also rooted in misconceptions.
Yeah, it's misconceptions. Yes.
Now, doctor, we're looking at contraception, saying that that's one of the factors that we then able to prevent pregnancy. But what do you need to consider when you're choosing a contraceptive method for yourself? Apart from now wanting to see your blood, like some of us that still have that rooted in us.
So there are a few factors that we need to consider as a woman who is, when you make that decision to choose a contraception, the first thing that you need to consider is that you need to look at, it must be an ideal contraception. An ideal is that you must take your lifestyle factors, and then in terms of effectivity, all the contraceptions, they are equally effective. However, I will speak about to the ideal. So the ideal contraception is the one that will preferably will not fail. That's of course the aim. You want to use a contraception is that you want to prevent pregnancy. You don't want surprises. What we know is that depending now on the type of the contraception that you choose, there is a risk of contraception failure. So we usually look at contraception in two groups. We refer to the long-acting, they are meaning that they act for a long time, but they are reversible, and the short-acting, and this short-acting, it means that they may not take long to return to fertility. When you speak about short-acting, is that it is also drugs that require, number one, at least you use them at least every month, within a month. So these are, for example, the pills. The pills requires one to take the pills effectively every day, preferably at the same time, to prevent them from failing. Why is that the case? We want to achieve a constant exposure within your body to a constant levels of the contraception for them to do their job, which is to prevent ovulation. So that means requires, number one, a good discipline and also responsibility to make sure that you do that. Patch requires at least from, depending on the patch that you're using, you must change them at least once to twice a week. So that also requires an effort, meaning that you must not forget them, because if you miss a pill or you miss to change your patch, you can end up with pregnancy. And then others are using rings and that. Then we come to the other groups, such as the injectables, for example, Depo 3 months, null estrate 2 months. Those ones can also be considered as a long-acting, but obviously they also require a lot of effort, meaning that you must make sure that every time. So then we look at the other ones now. If you look at what we call the group of long-acting but reversible, so is that, for example, if you look at the loop, the minimum loop up to now, the latest, for example, in Mirena is approved for up to 7 years now, meaning that we put it in today and you remove it after 7 years if you want to fall pregnant, or you can replace it, or any time in between those 7 years, maybe after 3-4 years, you can remove it and then fall pregnant immediately. The same goes with the implant. Most of them are usually minimum of 3 years, and we put it today, you come back after 3 years. So if you look at that, and now you need now to look at the 4 factors that we want. It is which one is more ideal in terms of it must be less user dependent, preferably. The user must not make an effort to remember that I must take a contraception. It is so the lesser user dependent, the better. And if you put in a loop and you put in, for example, an implant, the likelihood of these two failing are also very, very low, because they are there, and you don't need to remember about they are there. You just know that they are, for the next 3 years you are covered. So at the end of the day, then you need now to also ask yourself, what are your goals and benefits? So if, for example, someone who is at school, at university, you'd want to have something that is consistent, that will not disturb you, and you have an implant or a loop, and then you know that for those years when you are busy studying, you are covered. And then also the issue of affordability is also another. For example, if you are a student, sometimes you get money, instead of buying money for contraception, you may use them up for something else. But if you have a loop, or you have, so those are the factors that we look at the end of the day. You need to look at, must be less user dependent. It must be user friendly. You don't need to drink them. You put it in it once and you forget it. It's probably like for the long acting ones. And then it must also be affordable, and it must also be then widely available and accessible, and all these ones. So that those are the 4 components that we look. And if you look at the ones that we have unpacked here, you find that we tend to lean to or advise patients towards the one that will meet all these criteria is mainly the long-acting reversible contraception. But at the same time, we also always encourage for a dual contraception, meaning that we have these drugs or medications, but at the same time, the couple should be using condoms, especially to prevent sexually transmitted. But especially if you are perhaps if you are in a faithful one-partner relationship, then that can be argued that if you may not use condoms, because contraception covers pregnancy.
Well, doctor, let's speak about the surprises. I mean, we've all seen the memes of either a baby carrying an IUD, a patch, and you're like, I had a patch, but where did this baby come from? What are some of the common mistakes that we do that lead us to these surprises?
Yes. So again, this is probably a follow-up question to what we just discussed earlier. Mm-hmm. So I highlighted that these drugs, the good ones, there's what we look at, and we call it a pair index, and in simple terms is that how many pregnancies in 100 women that we see if using a certain contraceptive method per year. So if we are to, and we use that to when we cancel, for example, if we look at these long-acting ones, mm-hmm. That is a loop implant, they are comparable to being sterilized. And the chance of a woman falling pregnant per year is not 0, mm-hmm. but it is less than 1. So it is, and in other words, we are putting it as very, 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 very low. Not impossible, mm-hmm. and that answers your question why we have children that are having loops. But that has to do with how we put in the implant. As a principles of, for example, putting in an implant, mm-hmm. the only reason implant can fail is not because it's not a good contraceptive method. The implant is positioned in the uterus, mm-hmm. and we always encourage that after we put in an implant, 6 weeks after insertion, a woman must be seen and have an ultrasound scan to confirm where is the position of this implant. If the implant is not in the womb where it should be, it will not, there is a risk of pregnancy failure.
The IUD.
The IUD, sorry, my apologies. If the IUD is not in the right place, then there's a risk of pregnancy. And this is how now we have seen these cases of newborns being born with IUDs on head. It has happened. And that is why the risk of failing is not 0, mm-hmm. but it's less than 1. So it can happen. So it's one of those rare cases, in other words. But if we look at, for example, as you move to other drugs, for example, contraceptive pills, the number of it is about 18 mm-hmm. women in 100 that fall pregnant per year if we are using pills. In other words, if we take 100 women, we put them on oral contraceptive tablet pills, most of the time what we see, at least 18 will fall pregnant. And this now has to do with how they use them. That's what I was talking about, the behavior. Are they compliant? Are they taking them on time? All these things, or they are missing pills. So the likelihood of you falling pregnant on a pill is higher, for example, when you have an implant, mm-hmm. or when you have a loop. And then when you come to others such as condoms, that is even more higher. So that's why we don't encourage people to use condoms as a form of only contraceptive method, because the likelihood of you falling pregnant, those ones can be up to more than 18, and I'm sure we understand why.
Well, there are a lot of factors, especially when it comes to now using a condom, maybe them busting, it being incorrectly used.
But, and also, just not being used at all.
And then we get those situations when it's fast in the moment and it happens. Now, doctor, let's speak about, since we're here, if the condom busts, what's the backup method? Where do I run to just so I make sure that...
Yes, that's a very good question, because it is not well spoken about, the role of the emergency contraception. So that is also one aspect of contraception that is not well spoken about, but it is a very important aspect, that if you have an unfortunate incident, not only condom busting, or even if you have an unprotected sexual intercourse, if you go to any pharmacy, they should be able to offer you a form of an emergency contraception, and you don't need a prescription for that. And we really encourage that if you are not planning to conceive, and that is the case. And by the way, what is also important is that some women, is that we need to understand that the issue of ovulation. We know that depending on the cycle, most of the ovulation is around day 14 of a 28-day cycle. But each and every woman must understand and study their cycle, so that they know when is their day 14 or around the ovulation. But what is also not well spoken about is that if you have sex up to 5 days before your ovulation, you can equally still fall pregnant, because sperm can survive up to about 5 to 6 days in the female genital tract canal, and they can still fertilize an egg that is just being to be ovulated. So that is also very important, that perhaps if you have, say, unprotected sex within also those time frame, one must consider to use emergency contraception. The most widely accessible ones is the pills that you can get from any pharmacy. However, it is also highly advised, one of the emergency contraception, which is also not well spoken about, is for a loop. If you have an emergency, if you have an unprotected sex, and you are worried that you are at risk of pregnancy, you can get a loop inserted, especially the copper T, and then that prevents pregnancy up to, and the good thing with the copper T, it can prevent pregnancy up to 5 days, meaning that if you have sex today, you have up to 5 days. And if we put in the copper T within those 5 days, you'll be prevented from pregnancy. And the other advantage of that is that we put it in, and then it is also one of the long acting, then maybe you know that you are covered, you will not come back for another mistake. The other ones, orals, they are only up to about 72 hours, within those 72 hours. But preferably the earlier the better. You must not wait for 72 hours.
Is this readily available?
Very much. The pills, most of the pharmacies are stocking them. But and then the loop you must see a doctor. Then they can insert it. In that one, you need at least a doctor to insert it, because it's a loop. It's just a different type.
Now, doctor, I was about to ask you to walk us through this emergency contraceptive, because now it's a situation of, when do I take it? How do I take it? Must I take several of them, or how does it go actually?
Yeah, so depending on the type. So the issue with the contraception is that there are two different types. There's what we call combined. Then there's progesterone only. The best one is progesterone only, mainly because, and those are the ones that we mostly find in the pharmacies, where you take 2 tablets, and then or 1 tablet. 2 tablets at once, or at least 12 hours apart. That's usually the progesterone tablets. There's also some contraceptive pills, but you take very high doses, and it can be used, but it is less of the not really recommended, mainly because it does have very bad side effects, and most women start vomiting, and then they stop. They stop using it, or also when you take it and you vomit it out, it will not be effective, and you end up pregnancy. But when it comes to the progesterone only, the ones that you take, they have less side effects. You take them, you are fine. They are actually good.
Okay, you take them, you should be fine.
Yes,
absolutely love it.
So the ideal time to start a contraceptive method, preferably it should be when you start your menstruation period. So if you are starting today to bleed, Because when you start your menstruation period, that is your first day of the cycle. So that is an ideal time. Preferably, you start taking contraceptive on that day, especially contraceptive pills. They are good. And then the other ones will probably then insert it immediately after you stop. For example, a loop, you can put it in immediately after you stop. But around the menstruation time, that is when you must ideally be having that contraceptive started. But it also depends on the time. The orals, you can start them on the first day that you start bleeding. And then the other ones, like a loop, we put it in the implant, we can put it in at any time. And yeah.
Okay. Doctor, what's the one piece of advice that you give to someone who's considering starting their contraceptive journey, or one that is facing infertility?
So when the most important thing, like I said earlier, I highlighted this briefly in a sense that when you start contraception, you need to consider what the objectives. What you're trying to prevent pregnancy, yes, but what are your time frames? Is it on a short term? Is it on a long term? And all that those are the factors. One, and also then looking at what is how is your life schedule? Are you someone who works, for example, night shift that require you to work at night? Will you have enough time to be able to drink? Are you always at home at the same time? So those are some of the factors that one needs to take into consideration when you choose a contraceptive method. But obviously, at the end of the day, we're not saying that, for example, pills are not good for form of contraception. It all depends. All the contraception are equally effective, but the lifestyle and the behavior on the user do have an impact on the outcome of the contraception.
Amazing stuff. Thank you so much for your time, Doctor. But before we can be able to let you go, we are moving on to my favorite part of the podcast, which is now the fire chats questions. These are a set of 3 questions that allow us to somehow get to know you better and get to understand the profession that you're currently in. And for someone who's worked for more than a decade, wow, how do you do it? It's one same job every day for over a decade. How is that going?
Yeah, no. In the field that we work, every day it's a different day, because we don't see a patient every day. You see a patient with a new disease, and we learn every day. We are seeing new disease every day, and some of the disease you learn about them in the textbook, and in the past 10 years you have never seen one, and you only came to see it. Say, for example, this year. So this is a type of a profession that we are in. So every day is new. It is exciting, and so far I think I'm enjoying my job.
Now, Doctor, the first question for the fire chats question is, what's that one surprising thing that you've learned over the decade that you've been in this industry about how we as Namibians approach contraception?
Yeah, so the first thing is that I think that I would highlight is the truth of there is less use uptake of contraception, in a sense that I feel like the people are not well informed on the role and the benefits of contraception. And we see this because I also work in the public sector. And we see women coming and every day. We know we can, in a sense that you can see that a patient comes, and when you take history, there might have been some form of unsafe termination or in pregnancy interference, and you offer this person contraception, and they will tell you, no, I still don't need contraception. But I mean, you just came and you just fall pregnant, and you are going back into the same unsafe environment, and you are most likely to come back. So I don't know whether it's an issue of we're not doing enough in terms of educating the benefits, and also perhaps it's because of a lot of myths that are out there that if you use contraception, you may have fertility issues and other issues where you want to see blood, like what you were saying. So yeah, I really quite find that quite very surprising, because when you look at a role of contraception that they have in the society, especially in the obstetrics and gynae, it has been proven that contraception do have a role to play prevention of unwanted pregnancy and the teenage pregnancy. The fact of the matter, or the reality, is that our young people are engaging in unsafe sexual practices. And I think it can only be fair for them, at least while these things are happening, that we advise them to really teach them on what they must be doing to be responsible and to take up a contraception. I'm not advocating for for sex before marriage, but if you are engaging in sexual intercourse before marriage, I think it's irresponsible for you not to consider contraceptive method. And I think that should be the message. I think we really need to do more and educate our people on that, so that we prevent unwanted pregnancy. We also prevent maternal deaths. We're losing young women. In this December at Katutura, we lost young girls. One is 19, two actually 19 years old, and one was a 16 years old, and they died as a result of complications from pregnancy. And surely a 19 years old and a 16 years old, surely these are unplanned and unwanted, and they died. So I think we really need to do more, and I think and this is what I found, that the uptake is quite low.
Well, I like how he's highlighted the fact that young people are engaging in sexual intercourse. That's the reality. The teenage pregnancy, the statistics speak for us, and we don't want to lose more lives. So definitely signing up for contraceptive or contraception could be a good choice if you're sexually active. And if you're not and are waiting for marriage, even better. Doctor, if you could create one ideal contraceptive method, what would it be and why?
That's an interesting question. If I know there are ongoing trials. We have not really reached a good success yet. But that ideal contraception, perhaps it will be a male-based contraception. We only have one option, which is not relevant, especially for most people of the reproductive age, because contraception is mainly for young people that are still planning to have a family perhaps later, which is a vasectomy. But perhaps it will be interesting if we can get, for example, an implant or a pill in the market for us males. It will be interesting. That will be my ideal one. And but just on that note, yes, there are studies, and perhaps in the near future that will be a reality. I would be interested how the society will change, hopefully, and accept this form of contraception.
We'd also love to hear from you as our listeners. Would you be bet, or would you be down for such a contraceptive, or what would be ideal to him? Or what would you consider as your ideal contraception that you can possibly create? Now we're moving on to the last question for this Fire Chats question, and we'd like to know, what's that one thing that you wish people knew about infertility that is often overlooked?
Is the reality of the biological clock, especially in females, that the truth of the matter is that you are born with a finite number of eggs as a woman, and every day you lose one egg, or at least even more, to a point where that when you reach that critical age, more especially beyond 38 years old, we see a sharp decline or a significant decline in the number of, number one, number of eggs, but the second one is also the quality, in a sense that at the end of the reproductive career, which usually lasts when you enter around your fourth decade, is that the eggs are few, but whatever is also left, they are of poor quality. So women need to read and understand about this fact, and they need to plan their family bed, perhaps on how to, even earlier than preferably before that. Or if not, then they must be asking questions about methods to preserve their good quality eggs at a younger age. And this is when we speak about egg freezing. And because if we take an egg of a 25 or a 28 years old woman and we use it 10 years later to fertilize it, it will still be the egg of the 28 years old, which is, we know that at that age, those eggs are of very good qualities. So I hope that that is one thing that I think women should read up more about the issue of the biological clock, because more especially in a new modern context where there is a lot of demand in terms of academic job. People want to focus first on the academics and before they really start family, and sometimes they start too little too late.
Well, fellow women, I hope you're hearing about the biological clock. And I think I'm going to leave you with a homework of please do check it out. See what is suitable for you. No pressure, but you might need to preserve more of your eggs and see what can possibly work for you. And with that being said, we've come to the end of our episode. Thank you so much, Dr. Emvula, for your valuable insights and sharing your over a decade of experience in gynecology with us. And we hope our listeners have been able to walk away with better understandings of infertility, contraceptions, misconceptions, and also a bit of insight on the biological clock and emergency contraceptive. We loved having you here and we look forward to having you yet on another episode of Sex Talks Podcast. And to our listeners, you can be able to access the podcast on Spotify, Apple Podcast, or our website, or engage with us on the various social media platforms. And with that being said, amigos, adios.